So in the continuum of care of patients with metastatic colorectal cancer that is not resectable and not curable, we go through different lines of treatment. Now, the number of lines of treatment will vary dependent on many factors. It will vary based on the molecular profile of the tumor. For example, if you have a patient with a RAS wild-type tumor, you could envision that that patient may get 3 lines of treatment. If they don't start with an anti-EGFR agent and they start with an anti-androgenic agent, such as, say, Avastin or bevacizumab, and then they progress and the physician chooses to proceed to bevacizumab or plus aflibercept, that patient has already gone through 2 lines of treatment. That patient still has a very effective line of therapy, which is anti-EGFR therapy, so that should be the 3rd line of therapy in that particular scenario. It's only then and after the patient has progressed on all effective therapies that I would consider regorafenib in a patient with RAS wild-type tumor. So regorafenib has been approved based on the correct clinical trial, and that study is in patients who failed or progressed or were intolerant to all systemic chemotherapies and to anti-EGFR therapy in the setting of KRAS wild-type tumors. So it's fair to say that regorafenib should be considered, irrespective if it is 3rd or 4th or 5th or 6th line for that matter, after a patient has progressed on all effective therapies. Some patients start with a fluoropyrimidine, then get FOLFOX, then get FOLFIRI, and then get anti-EGFR therapy. That's 4 lines of standard of care in that particular patient. In that particular scenario, regorafenib would be 5th line. So usually regorafenib should be really left until we have exhausted our systemic chemotherapy and anti-EGFR therapy. And yes, we do use it. We sit down with the patients and we are honest that this is an agent that certainly improves overall survival, but the improvement in overall survival is modest. It is a hazard ratio of 0.77, meaning that there is a 23% improvement in overall survival. But the absolute difference in median overall survival is somewhat limited. There are some patients who will not progress at 6 months, but that's a small fraction of patients. These are the patients where we consider regorafenib. Now, as far as to what is my starting dose, now we have to remember that the correct clinical trial enrolled patients with ECOG 0 and 1. So these were patients with very good performance status. If I have a patient who has a very good performance status, ECOG 0 or 1, is not an extreme elderly, is not 80 years of age or 85 years of age, I am comfortable in that patient to start at the recommended dose, which is the proven dose, and that is 160 milligrams once a day, 3 weeks on and 1 week off. What do we do to monitor those patients? In the first cycle, we bring them in weekly to monitor them. Because most of those patients, if they're going to get sick, if they're going to have the hand and foot syndrome, which can be severe in approximately 15% or so patients, or if they will have a significant rash or mucositis or diarrhea, that typically will happen in the first 1 cycle. So that is where you want your intense monitoring to occur. In a patient who is a little bit on the older side or has some limitations, some comorbidities, I may actually start at 120 milligram, which is 3 pills once a day, 3 weeks on and 1 week off. And if that patient tolerates cycle 1 without any significant toxicities, then I may consider escalating in cycle 2. So regorafenib has been also investigated not only on the correct clinical trial, but also on the CONQUER clinical trial. And the data has been presented at ESMO in 2014. It is important to note that it's a different patient population. The CONQUER clinical trial is a much smaller study than the correct clinical trial. It's about 20% of the patient population of the correct clinical trial, so it's not as powered. The other thing that is important to mention is that the CONQUER clinical trial did not mandate that the patients should have failed anti-EGFR therapy. And it also did not mandate that the patient would have received or not received bevacizumab. On the correct clinical trial, all patients had received bevacizumab. On the CONQUER clinical trial, in excess of 40 patients had not received targeted therapy, neither anti-EGFR therapy nor bevacizumab. Now, clearly, not all patients should have received anti-EGFR therapy anyway, because many of them have a RAS mutant tumor. But it's important to note that many had not received, a significant portion did not receive bevacizumab. So the interesting thing about the CONQUER clinical trial is that for a patient population that has failed chemotherapy and progressed after chemotherapy, the overall survival was pretty good, 8.8 months. And that's a significant number for a refractory patient population. And the absolute difference in median overall survival was also notable. It was about 2.5 months more than the placebo group. So that was a little bit better than what we had seen on the correct clinical trial. On the correct clinical trial, the hazard ratio for overall survival was 0.77, meaning 23% improvement in overall survival. On the CONQUER clinical trial, it was a 45% improvement in overall survival, relative improvement. So the hazard ratio was 0.55. Now, it's not very clear why the results with regorafenib were actually tended to be better in the Asian population than they were in the rest of the world, or we want to say North America and Europe, is not very clear. One theory is that the improvement in overall survival was a little bit better because it included a cohort of patients who did not receive bevacizumab, did not receive anti-angiogenic therapies. And indeed, if you look in the subgroup analysis on the CONQUER clinical trial, it appears that those patients who had not received any targeted therapies had a more robust improvement with regorafenib as far as overall survival. I think the important message from the CONQUER clinical trial is at least it confirms the findings from the correct clinical trial, that for patients who fail everything, there is an improvement in overall survival if you use regorafenib. And it is in patients who have seen bevacizumab, maybe the hazard ratio of improvement is a little bit less than what we have seen on CONQUER, but nonetheless, it is an active agent in the Asian population and in the rest of the world.